that's really built for urgent care. And it can seem very easy with all of the front challenges we have on the front lines of the system to say, well, does it really matter if we deliver a banana? And yet, if we all think of the things that are important to us, how many of us have come home at the end of a long day and we want to do exactly what we feel like doing in the moment? And when that liberty isn't available to us, when it's been taken by the ravages of time, then it is absolutely essential that somebody remember how desperately we need that sense of normalcy. And that story, I think, has been a bit of a talisman to us in the office, that it is always important to remember that as we age, as we become more vulnerable, as we rely on others, we still remain very deeply ourselves and deeply human. And we need a sense of normalcy. We need a sense that our preferences matter. We need to be heard and we need to be seen. And we've tried to be guided in that. And then, of course, the challenge in policymaking is to take those tiny views and to build them into questions of how do we make a system predictably do that, which is different from just wanting it to work. Systems don't always bend themselves easily to producing the right result every time. And that's why we addressed in this report the question of governance. So here is what I might gently suggest are the challenges, and ones that I think we have at least a promising beginning to. That there were sort of 7 themes that we identified in the long-term care system. One, that it should feel seamless. That whether you are at home needing a little extra support, or whether you're in a special care home with some independence, or whether you're in a nursing home with even more supports, that it shouldn't be 3 systems that are each highly centralized, but a system that's decentralized where people on the front lines can easily guide people through to the care they need in the moment. That it should be accountable. There should be a sense among all of us who may have family members in any facility that there is some way to say something isn't right without fearing retribution, and there should be some way to know that when you go home and you entrust your loved one to the system, that there are ways we will know early if there are problems, if there are places that are not blending in with others, that we're using small area variations, that we have protection for people, that the system should be affordable, that everybody should be able to say with and depend on the fact that they will not be denied the care they need for financial resources. And there should be ways of making sure there are limited surprises, and that families are able to, when one spouse needs more care and the other's in the home, that it shouldn't be devastating on the remaining spouse. That it should be high quality, that if you do rely on others, they should have the time to do the things that make you feel completely human. They should have time to know when you need a banana. We should have the same hours of care as other Canadians. We should make sure that it isn't just doing the bare minimum to keep people alive or medicated, but that it's actually about engaging with patients. We should know that we have incentives that match what we want. This is the governance challenge. Do we truly create a system where people are accountable for providing the right intervention, or that people are there for following the rules? That we should make sure we don't wind up with somebody in a hospital bed awaiting costly long-term care when an intervention that was just a little bit more than the rules allowed was available. How do we make sure the system responds to that when we know we are developing better and better mechanisms of supporting people in aging in place? How do we make sure the system is built to steer things there even when the rules can't capture every possible situation? And are we thinking of the future? Are we preparing for the challenge for seniors down the road? Are we addressing things like the growing number of needs for dementia beds? Are we thinking about what the demographics will be? The next generation of seniors are going to be more diverse. There's going to be a number more people whose sexual orientation or gender identity is different. There's going to be more new Canadians, more people from diverse cultures. Have we accounted for the very different attitudes and approaches that First Nations have towards family and aging and obligations? Do we have a system that is responsive enough? So those were the challenges we put out there. Et je dois être honnête, ça c'est honnêtement beaucoup. Parce que quand on a parlé au Néo-Brunswickois, il dit quelles sont vos réflexions sur le système de soins à longue durée, d'être honnête, il y avait beaucoup de réflexions, beaucoup d'inquiétudes. Le, le niveau d'inquiétude entre les Néo-Brunswickois, c'était vraiment remarquable. C'est plus que j'ai anticipé parce que on sait bien que d'être pluvieux, c'est simplement un fait de la vie. Et tout le monde le sache, mais d'habitude, on passe la plupart de nos journées de éviter de penser de ça. Mais au cœur, on sait bien que probablement, il sera une journée quand on doit mettre la reliance sur les autres pour notre bien-être. Et d'avoir la confiance que nos besoins seront rencontrés, c'est absolument fondamental d'avoir un sens de sécurité individuelle. Et on l'a entendu de beaucoup de citoyens quand on a fait les consultations. So let me just talk very quickly about some things where I think we have a lot of promise. One, I think it is a tremendous opportunity that we are going to have a proper long-term care act, and that process, if handled well, if really engaging, if allowing for input along the way, if having a process that ensures that there is real input into the act, if that's happened, I think it can be a tremendous opportunity to bring the sectors together. And the directions governments are taking to think of one continuous system are very consistent with the ones that were in the report. There has been, and I have to note this with genuine recognition of government's work in this, there's a real commitment to increasing accountability. The fact that recommendations like whistleblower protection were accepted without significant debate was very meaningful. That there will be a number of indicators, that there's going to be an effort to be honest about data. And the department has walked the talk on this. I have to note that after 3 years of saying government should start to have some indicators of how children in care are doing, government has actually done it and released, for instance, the graduation rates. The bad news is they are not remotely close to where they should be. The good news is, at least now we know that. And people in the regions can be accountable for having to work to increase that. And the commitment to be able to say this number is not at all flattering to our work, but we're going to put it out there, is an important culture change. And when government says the same thing on accountability, that is good news. There has been significant work on having one seamless interaction with the system so families aren't overburdened with financial paperwork and uncertain whether or not, if their care needs change, they're going to still get support. There is a genuine recognition of that, and that's been extremely important. The commitment to place seniors' rights in the legislation, and how we do that is going to be part of the art form, but I think that's an important recognition. There's an old saying lawyers are fond of that comes right from Latin in the very basic, where there is a right, there is a remedy. And certainly before, one of the areas where the legislative process worked extremely well when the Child and Youth Wellbeing Act was adopted 3 years ago. It was extremely important that the majority at the time was willing to say, look, even though we've introduced it, we'll accept some changes. And one was to have a more affirmative statement of what the rights of children in care were. That's equally important here, because when we say these are the things that must absolutely be protected, we're actually creating a counterbalance to rules and procedures. We're creating a sense that, remember, these outcomes are essential. Every individual matters. And government's willingness to do that is extremely important. So I think when you look at this, not only are there areas where there's been real engagement with the 7 themes of the report, there are, in those directions, a clear commitment to an act that, if those things are realized, can be a real groundbreaking piece of legislation. Now, that relies on process, it relies on drafting, and there's a lot of work ahead. But there is alignment here, and I think that's a promising start. Il y a aussi, comme vous pouvez voir, il y a certaines recommandations ici qui sont de nouveau. Simplement 6, mais il y a une raison pour ça. Parce qu'il y avait les places où, en notre opinion, il reste une différence entre ce qu'on a entendu dans nos consultations et ce qu'on a recommandé dans le bureau de Défenseur, et à ce point, la direction de la ministère elle-même. And so we've put out a couple of alternate recommendations for areas where either time has changed the situation or where there may still be some differences in alignment. And this is, in many ways, our effort to say, well, look, if the recommendation originally wasn't what government can do, but they are willing to do something, we would at least say, here's for us what we would consider a bare minimum or an alternate way of getting jobs done. And I want to highlight those because I think some of them are important. Certainly when it comes to adults with disabilities, and on the income support front, there has been tremendous work. We would invite the department to do some serious work about standards of what is and isn't acceptable and timelines as to when placement should be revisited. It falls into the category of things that are easier said than done. And I know that because I've wrestled with it too. It seems to me that when we have younger New Brunswickers with disabilities in nursing home facilities that are not designed, that is on some level of failure. And it should be recognized as a negative outcome. We had proposed actually setting a date for a moratorium on the practice. The department isn't there yet. But what we have said is at the very least, there should be some standards and there should be two areas. One is there should be levels of what is and is not acceptable. And we've seen, some cases recently with some placements that really are either in places that are not providing the right kind of environment for people with disabilities or don't have a path to the kind of community supported placement that adults with disabilities deserve. And so we would invite the department to come up with standards as to what is and is not acceptable. If the labeling of nursing homes isn't to their liking, then we would say that let's come up with some boundaries. And let's also have a process that recognizes that some placements, even if they may be necessary in the short term for safety, should have an automatic level of revision and that regions should be accountable for that. So again, that's an effort to continue the dialogue and say, well, here's what's important and here's where we're still not meeting. On First Nations, we think there's more opportunity for government collectively, and this goes beyond the Department of Social Development into all three, but there is not a truly distinct engagement process with First Nations government. And it seems that when we think about the cultural differences for elder care and the different approaches to family, that having more opportunities for community-based placements and more opportunities for resources with First Nations government is an opportunity. There's one thing we've suggested that government take a look at the tripartite agreement. So some years ago, the Department of Education discovered that First Nations schools were not getting the same opportunities in literacy that other New Brunswickers were. And there was an agreement signed that actually said, let's take some of the money that is provided for this service and place it under joint management of school districts and the First Nations government so that First Nations governments are actually equal partners in developing that process. Literacy rates went up about 60% in First Nations schools 5 years in. It took all three levels of government. And something that we've proposed is that this is an area where a formal engagement process with First Nations governments and the feds, instead of simply saying that's a federal responsibility, there is an opportunity for the province to be a catalyst there. The other area that we have approached is with some concern alternate levels of care or patients who deserve to be in the long-term care system, but find themselves still in a hospital bed. And I think this is, and I want to preface this comment with this statement. This is a prime example where we sometimes talk about fiscal deficits and the moral case against them, which is that if we spend more in a given year, we may pass expenditures on to future governments and therefore limit their options. Not all deficits appear on a balance sheet. It's a deficit when you pass on a fiscal deficit. For sure it is. It has to be dealt with. It has to be paid for. Just like the credit card. Look, sometimes the roof leaks and somebody's got to fix it, but it will limit your choices later. And that's fair, and I don't diminish that side at all. But if we pass unmet social needs on to other future generations, those are equally deficits. They limit the choices that we have. and they restrict opportunities later on. And I say that because this has been a priority area, as I think it rightly is for our office. It did not develop over the past 1, over the past 8, or even over the past 15 years. The fact is that a number of governments knew there was going to be a growth in demand that could not be met by capacity. And it was expensive. And it didn't get dealt with. And as we've seen it, when you do that, it forces governments to make more and more choices in desperation. And so what we've said is, look, this didn't all develop in the last year, but it absolutely has to be dealt with. It is destabilizing two systems, and there are not easy answers, but we made a couple of proposals. One, it would make a lot of sense to have a system that before there's any admission of somebody who should be in the long-term care system to a hospital, somebody senior in each region should have to review and see if there are even extraordinary expenses that would allow them to use a different space within the system and to sign off. Because one of the problems, as we noted in how it all broke, is very often we hold the system accountable for following the rules, but not for the result. That there are still incentives in government that say if you go $2 over in your own department, you're in trouble. But if you pass a $10,000 problem to another department, you done good. And finding ways to make somebody responsible for the overall impact rather than just the process could be absolutely essential there. And I want to close with this thought. I think there is a lot of merit in the data that is being proposed to be collected. We've made a couple of comments on that. One is, let's remember that there is more to the long-term care system than simply avoiding medically adverse incidents. And we have to balance not only problem avoidance, we have to have quality of life indicators and other indicators that speak to issues. And I would always put this challenge there. It's something that is at the heart of what we do as we, in the advocate's office, start to raise issues of social policy governance. In the end, what matters is what you give people on the front lines incentives to achieve. I've lived long enough to see a great many government plans. Sometimes I've even been the smiling minister with the words there. And so when I say this, I'm not diminishing any past or current ministers. We've all done that. What a program about isn't what you write next to the smiling picture of the minister. What a program is about is what the people delivering the program are accountable for achieving. And sometimes there's a big divide between those two. We write in social welfare policies that we want to support independence, but very often we put families through a process that yanks back tiny supports that would build independence simply to save a few dollars or create a short-term incentive for low-paid work. Often in education, we say student outcome is most important, but if you connect it to what people are evaluated on in the system, you don't always see that connection. We know it's important to keep people in their homes longer, have community placements for people with disabilities, but is it part of the outcomes that regional offices of social development are evaluated on? The indicators are good, but we would invite the department to consider one important question. When the indicator isn't met, what happens? And if that isn't built into the structure that holds regional offices and frontline workers accountable and evaluates their outcomes, then it's a wish. And that's absolutely essential. So look, this is a snapshot in time. D'avoir le dialogue, ça, on doit avoir un peu de patience avec le temps. But I think this is a good day. There's been a consensus around some important themes. We have a process through the development of a new act that will hopefully bring all the voices we heard to the table with government, and they'll balance them all. And there are challenges. But of course, that's how public policy always is, and I always remind people of this. It's easy to be cynical about government. But I've been to an awful lot of countries where you don't have the automatic belief that when you get up in the morning, the buses will take kids to school and the ambulances will take people to hospitals. And when families struggle, somebody will show up to help. And if you had to build it from scratch, you'd realize how amazing it is we have it at all. We've built, for all the cynicism about government, compare the outcomes from everything from life expectancy to social outcomes to 100 years ago. It's a pursuit worth doing, even when it's time-consuming and awkward. And so I think there is something powerful in the dialogue between trying to make what we have and what should be the same thing. So thank you very much for your time with that this morning.
Thank you very much. Okay, we're just going to take a moment now, and I'm going to, Kelly, don't ruin the stage. I'm going to take a moment and I'm going to welcome our guest panelists this morning to this stage. And so I invite Dr. Janet Durkee-Lloyd, Associate Professor at STU with the Department of Gerontology, Danny Soucy of Inclusive Employment with New Brunswick. Sorry, Danny. And Ken McGeorge, Health Administration Consultant after being President, CEO, and Executive Director of several health organizations. So if you guys would like to join me up here on the stage, that would be great. And while they are doing that, I just want to take a moment and thank our partners. So your treats out front are provided today by the Third Age Center. So we want to thank them very much for partnering with us. The Center for Best Practice partners with the McKenna Center here at STU for a great deal of our initiatives. And for anyone who's unfamiliar with the Center of Best Practice, that's okay. We're relatively new. We are a new branch of the Office of the New Brunswick Advocate. The Advocate had a plan that he wanted to have part of the office really being focused on upstream solutions and trying to get ahead of situations before he needs to write a giant 50-page report about it. And so I have the pleasure of leading that work along with some amazing colleagues, and grateful for that work each and every day. So right now, I'm going to turn the mic back over to the Advocate. He's going to monitor this panel of experts, and we'll continue our morning.
Well, good morning, all. I guess I get to tower over you. I don't get a chair. No, it's fine. This feels odd. I feel like, Gabe, this is the giant tiger version of Jerry Springer. Hopefully Ken McGeorge won't hit Danny Soucy with a chair when we discuss people who bury their furniture or something. All right, now I get to put on my smart person glasses because I think that's how my life works now. Yeah, that'll work. Look, I'm going to start with questions that a few things that folks have want to hear people address. You have here a tremendous amount of expertise here on this stage. Ken has administered almost everything in the healthcare system that can be administered, generally successfully, and has a tremendous amount of wisdom. Janet is a leading voice in the theory and policy side, so I think we have a tremendous match here between the view from the literature and best practice and someone who's been in the trenches. And Danny, of course, has not only been part of the political process, but has been an exceptional advocate for people with disabilities and generally the cause of social inclusion. And so I think you're going to hear a tremendous amount of interesting thoughts. The first question I have for you to ask is, and I'd like to hear each of you address this, how do we shift the long-term care system from something that responds to crisis into something that can predict the aging journey and have services in place in advance? So I'll turn that loose, and you can each use your microphone. It's very important you tap and blow on each microphone, or you will be docked points on your final score.
How do you want us? You want me to go first? I should have sat in this chair. I should have.
Yeah.
So just for my own interest's sake and for yours, the minister mentioned the importance of education. How many people in this room are current or former students of our gerontology program here at St. Thomas? How nice is that? And they're probably saying, she's no expert. This is a very complex question with a complex answer. But the reality is that aging is complex in terms of how we manage to deliver services to people as they age. And one of the problems I see that's happening here is we're disproportionate in terms of the system as it exists and the needs that we have in the province. So I suspect in the next presentation we're going to hear that Dr. Sinnar is probably going to talk about some data that's just recently been released about Atlantic Canada. And when you look at the numbers, particularly about what older adults want, 85% of older adults in Atlantic Canada want to remain in their own homes. So unfortunately, we now in New Brunswick, our long-term care system seems to be driven by the crisis, especially lately, of the ALC beds. And that seems to be where all of the efforts are. And it ends up being an imbalance. And these things are inextricably linked. Home care, hospitalization, access to nursing homes and special care homes. They're all linked. They're not separate entities. So if you think about if someone's on the waiting list for a hip replacement, there's complex issues around that. There's the waiting for the surgery. There's the staying at home, the social isolation, the mental health needs around that. So there's needs for community supports, also needs within the healthcare system, and then perhaps eventually maybe long-term care because the home care supports aren't there. So it's complex. And because we are not balanced in terms of how we deliver supports, I think that's why we're always in crisis, because they're all linked together. They're inextricably linked. And I think part of it also is that we need a plan that gives equal value to all of those parts, and a plan that's informed by the users. And I believe the minister also said, nothing for us without us. And it certainly comes from the work of Ability New Brunswick in particular. And that is key. The voices and needs of the older adults need to certainly be front and center in terms of understanding what's needed and how we deliver those services.
I'm going to talk a little bit about aging when you have disabilities. Aging is complex, and the services that come are complex, but when you have a disability, it's even more complex. People who have disabilities, intellectual and developmental disabilities, generally in their entire lifetime, have not been seen as valuable citizens in our communities and have been told where and what and when to do things. And things are changing, but it's still that way today. And when you're aging, your little bit of rights that you had and the little bit of dignity and a little bit of independence or interdependence is actually taken away. So one of the things that I believe needs to happen is that, or we believe needs to happen, is that individualized, person-centered planning needs to happen. And it's not just with people who have disabilities, it's with everyone who needs any supports whatsoever. We also need to start thinking about the language that we use when people are aging. We keep talking about care. And when we talk about care, we do for rather than with people. And that takes away sometimes a lot of, often or all the time, people's dignity. None of us want to be, catered to and just sit there and wait. When the example of the banana was given, wait for that banana to come and wait and wait and wait. You want people to help you live the life that you want to live, whether you have a disability, whether you're aging. You want to make sure that that dignity of living the life that you want is happening. I just lost my mother last year, and her last month was spent in a care facility. And I saw people change the way they spoke to her because it was care. She then turned into a child because the way they spoke to her, they looked down at her, and she couldn't make decisions. They couldn't move. Everything stopped for her. Her dignity just left. And when I look at my own son, I have a son with a disability, and I know he's aging, I'm aging, and I'm thinking of what's happening, what's going to be happening to him if the right things are not put in place. We need early detection and prevention. We need to help families, and we need to help our community realize or learn how things are changing in people's lives so that we act now rather than wait until it's too late. If families had more information about aging and more information about people who have disabilities and what are the signs that they may need more supports, providers should have the same type of training. Community-based supports and housing is another thing. Extend prevention program services and include housing options to help seniors with intellectual developmental disabilities maintain health, independence, and connections. And remember, connections is one of the things that keeps us going. If we go back to COVID, all of us felt isolated. That's how a lot of people who have intellectual disabilities and seniors feel on a daily basis. Imagine living the next 10 years in that, with that feeling. System-wide registry and monitoring. Know about who is out there. Know early. Our systems know that Joe has a disability, Jane has a disability, and the complexity of that disability. Helping, knowing that they're there, planning in advance to make sure that things are positive when they need supports. Cross-sector collaboration. Now, we've talked about silos, and we do. I was a minister in government. I saw the silos. I think they're still there. And if people tell me they're not, then tell that to the people that are asking for supports that have to go and tell their story over and over and over again, and being told that that's not our department, that's the other department, that's not this department, that's the other department. Does any department actually do it? So that's what people are asking. Workforce development. Strengthen the training of people that work with people. Talk about the respect. Talk about the dignity. Talk about the inclusive practices that need to happen to make sure that people have quality lives when they are being supported. I want to take care out and put facilitation. I want to take care out and put support. I want to take out and put accommodation, accompanying. And family and community partnerships. Engage really the families and the individuals in the decisions. Not just consult, but have them around the table when we write the document and then when we review how things are going. Families and individuals should be around those tables. Thank you.
Danny? Ken?
Well, my mind goes in the same directions, but from a different perspective. What New Brunswick is faced with, frankly, is, and pardon my voice, I had some major surgical intervention a year and a half, 15 months ago, and my voice has not come back yet. I'm hoping and praying that it will, but I used to be a bass singer. Can you believe that? That was the time. Anyway, I've been in the system, health and long-term care, hospitals and nursing homes since I was 19 years old. That was my first job. Nurses taught me everything I needed to know about care, as did some of the interns and doctors who were there at the old Victoria Public Hospital. That's how I earned my way through college. Then in postgrad, when I went back for graduate training in health administration, some wonderful physicians and nurses were faculty, and they taught me what doctors use every day of life multiple times over, and that is the process of going from symptoms to differential diagnosis to diagnosis. Strikes me in New Brunswick, this whole long-term care business, we've been talking about it for forever, seemingly, and looking for direction forever. And we've seen endless reports, one of which I co-chaired, all of which have been put out there as the panacea and the answer to our issues, and none of them were in the end result. That's why I so gladly welcomed Kelly's digging in, doing the deep dive that he did do. I salute him for that. Um, I was on my last working assignment in Ontario. I was there from 2000 till 2005. And Ontario at that time was faced with these same issues and lack of direction. And they created a long-term care strategy. And I knew the people that were putting it together. I knew the backgrounds. They were very smart people that I had worked with. They were not civil servants. They were not paid. They were not consultants. They were seasoned, experienced people who really understood the system. So I came back in 2005 to New Brunswick, thinking I was maybe hoping to early retire, maybe, but then had this wonderful opportunity to help them at York Care Center. And that was my first experience ever in long-term care. And I knew nothing about long-term care until that point. What I was hearing, though, during the months that I was here before I took that assignment, every day on the news, it seemed like there was some negative crankiness about long-term care in New Brunswick. I could almost replay the tapes from those days. That was, knowing that nothing much about it, that was the thing that struck me, the crankiness. And mind you, that was just 3 or 4 years following a very nasty strike. That doesn't help much. But so it was with a lot of anticipation that I went over to York Care Center, and some of the team are here today, and we just had a whale of a time. But long before that, back in the 70s, every provincial government was experiencing the same level of challenge with healthcare costs. The federal legislation, Hospital Insurance and Diagnostic Services Act, had been passed in 1959. The provinces were struggling with the costs of implementing their version of that act in each province. I remember the discussions well. I was reading about them in the press daily. New Brunswick's answer to that in 1971 was to appoint a world-class consulting firm called Llewellyn Davies Weeks. And that firm studied the New Brunswick system and concluded that New Brunswick needed to regionalize its hospital and healthcare system. That was part of their overall plan. It took from 1971 until 1992 to get that off the ground. McKelvey-Levesque Commission in 1989 paved the way. In 1992, government passed the appropriate legislation, and they appointed people like Kent Tingley, me, and 5 others. We were the slaves on the ground that were doing the grunt work and taking all the hits from the public. The politicians did their job. The regulating staff did their job, which was different from implementation. I remember those days. So my point being simply, I think with long-term care, it's not a simple system. It's not a simple fix. There's no photo ops that's going to fix this thing. It's big. It requires a lot of attention on many fronts, and we need a process of the scale that we did in 1992.
So taking that challenge, Ken, and I'm going to ask each of you to weigh in on this. I want you to imagine a world where you had, say, the Minister of Seniors and the Minister of Social Development sitting in front of you taking notes. And I know that would never, none of us live in that world, but I just want you to imagine it. If there are any visual aids that can help you picture that situation, I want you to envision that. And then I also want each of you to imagine you've got about 2 minutes to answer this, because we do have to get through this. But what would be, well, the 2 minutes will be done. As to whether it's answered, I can't control that. But what would each of you say, if you had a year going into a government that was reimagining long-term care, what would be one thing that you believe could be done that would help restore public confidence in the system? And I'll just keep the same order. We'll go Janet and then down the line.
Such a simple question.
So simple. Explain World War II, use both sides. Of the page.
Exactly. So I've thought a lot about this one. I think the single most thing that could be done, as the two ministers are sitting in front of me taking notes, is that you have to signal that older adults in this province are a priority. So I believe it was last week or the week before, the Premier created a working task force for the homeless. That sent a signal that that's important. I would argue we're in crisis. We're around, and probably over 22% of our population are over the age of 65, and we're headed towards having one of the highest proportions of older adults over the age of 85 by 2050. That's not that far away. No, I believe it's 2043. So signal that they're important. Ken mentioned he's been the author of a couple of provincial reports on long-term care. Go back and read them. And I've made submissions to those committees. And here we are with so many issues not resolved. So I think that you have to signal that this sector in our province, this valuable sector, are important, and we're working towards trying to support their needs. That flat out, to me, is the one thing. We have to stop kicking this can down the road. You know, sometimes the baby boomers get blamed a lot for this bubble in the aging population, but unless something dramatic happens, people are still aging, and we have all the people coming along, and we're still going to have all of the challenges. And I would argue we haven't met those challenges with this current bubble, and we need to. So we need to signal that you're important, we're working for you, and we're actually going to listen to you. Danny mentioned about having those voices at the table. That's imperative.
Yeah. Danny, what would you like to see one year?
That was mine also. But
Well, clap for Danny too.
I'm glad you said it, because I can go on something else. So is launch a quality of life standard framework, something that's out there that says how this is going to work and how we're going to make sure that we guarantee real choice for people. That people, and I'm here to talk about people who have intellectual developmental disabilities, but it's also every senior, that they are, for our population, that they're not put into special care or nursing home as a default. There's a bed, that's where you go. This is what happens on a daily basis when somebody says, I can no longer live with my parents, I want to live on my own. Here's a list of places you can live. And that's not the way it should be. We should also, that this quality of life standard framework would talk about funding initiatives, new initiatives for people to live in community where they want to and with whom they want to live and what they're going to be doing. It would commit also to staffing and training standards so that people are well trained to work with individuals. We have good people working, but they're not trained to do the right things with people and to think about their dignity, to think about respect, and to think about life and how they want to live it. And also plan the transition. It would also force the transition of people with intellectual developmental disabilities out of the system that they're in now. They're in long-term, the special care homes or the nursing homes. This would force that to happen. And so that, to me, would be my first, after that first choice.
Okay, cool. And Ken, I'll even say, I know I feel badly about the next question because you had sort of said, well, there isn't an easy answer. I said, great, give me an easy answer. But I might even invite you, you could either suggest one thing that you think is important, or even another way, is there something that you would want government to hear that, look, there's 100 things that need to be done, but here's one thing that if you don't do this, I don't know if it's going to accomplish it.
Thanks, Kelly.
My pleasure.
Just like he was in the legislature. I watched him perform there too. Uh, if I were asked my opinion, I would say start first with a compelling vision. What is it you want to achieve, government? Do you really want to fix this thing and create a world-class long-term care system? Yes or no? And how would we describe that? Having said that, then we would work through a process of figuring out what would be the top easily implementable strategies that we could do. And there's some things that have been on the table for 5 or 6, 10 years that really haven't gotten the level of serious, well, maybe more serious than I'm aware of, but I learned when Jan Seeley got me involved in helping the long-term care system, for instance, I had no idea. The only thing I knew was a couple of homes that anyway, and they introduced me to nearly 500 homes across the province, and some of them were unbelievably superb. And I learned a whole level of long-term care that most people are totally unaware of. And so I would, point number 2, after vision, let's get at some of the low-hanging apples, including some of the things that have already been submitted to government, such as the differentiation of roles within special care, the cleaning up of the classification system and the assessment systems. All of those systems have been faulty or at least said to be faulty for years. And so that'd be my pick. I mean, if you want more sexy things, there's lots more sexy to do, but boy, you gotta start with the tough stuff.
Thanks, Ken. I appreciate that classification system is fairly central to addressing the alternate level of care issue as well, isn't it? Sure. Okay. I'm sort of saying the classification system you mentioned, I've kind of one question for each of you in your wheelhouse. One is, how would isn't that somewhat linked to the alternate level of care issue?
Oh, absolutely. Absolutely. For so many years, I did my graduate school thesis in 1969 on alternate level of care. Go figure. And in those days, if you had 7 or 8 patients in a 400-bed hospital, that was quite a lot. Well, look at what it is now. It's and the reason I've gotten very wired about it most recently, and several of my articles have dealt with that. I saw up close and personal in January the devastating effect of filling those beds with old folks waiting for long-term care. I took my wife in by ambulance. Literally thought she was dying in January. Literally, I've never seen her sick like that in my life ever. And I get in there, and here's this poor sick woman, and every possible square foot of space was populated with somebody on a stretcher. And the poor nurses and doctors were going crazy trying to make sure these people, as a matter of fact, they were doing some examinations on sofas and crazy places and no privacy. So I said to Mark Melanson, I said, Mark, this is third world stuff. This can be fixed, but it can't be fixed without a plan. In my field, I was schooled many, many years ago. One of my mentors said, if you don't have a plan, any old road will do. And that's what life has taught me for sure. So you need a
plan. Thank you.
vision
Yeah, no.
and plan.
Thanks for reminding us of the moral case of that. Danny, j'ai une question pour toi aussi. Bon, je vais le demander en français, because we can. Comment est-ce qu'on peut assurer que les personnes handicapées et les personnes les plus vulnérables Pour être certaine qu'il va trouver un placement qui est vraiment dans la communauté le moins restrictif et où il y a le lien entre leurs besoins et les services réussis.
Je pense que ça commence avec euh, le- le- la province dire qu'on va mettre les gens dans un environnement qui est le moins restrictif possible, qui va les aider qui va suivre la Convention des droits des personnes ayant un handicap, l'article 19, puis qui va donner le choix à les personnes de vivre où ce qu'ils veulent vivre, avec qui ce qu'ils veulent vivre, pour garder leur indépendance ou leur interdépendance, leur dignité, puis participer dans la communauté, qu'on respecte leurs droits. Euh, c'est aussi que on a une planification puis l'allocation d'argent, de fonds qui est individualisée à la personne. Pas tout le monde a besoin des mêmes services, puis tu bâtis pas une boîte pour essayer d'entrer les gens dans la boîte, tu bâtis autour de chaque personne. Quand on fait une planification centrée sur l'individu, puis individualisée, la personne reçoit ce qu'elle a besoin pour pouvoir vivre une vie qui est pleine et qui est avec dignité. Aussi, l'appui de la décision de faire des décisions pour soi-même. On a la législation au Nouveau-Brunswick qui aide aux personnes de pouvoir faire leurs propres décisions, qui donne le support, qui peuvent assigner quelqu'un pour les aider à faire des décisions. Mais il faut s'assurer que toutes les organisations qui travaillent avec les personnes qui ont un handicap intellectuel ou développemental aient la formation, puis respectent que la personne peut faire ses propres décisions avec de l'aide, que c'est la loi, les gens peuvent le faire. Puis c'est une nouvelle loi, puis je trouve qu'on n'a pas fait le travail nécessaire pour assurer que la communauté connaisse la loi, puis comment utiliser cette loi-là pour aider aux gens de pouvoir vivre la vie qu'ils veulent vivre. Il y a aussi l'habitation puis l'appui inclusif. Tu sais, de s'assurer qu'on pilote des nouvelles façons de faire les choses. Les gens ont des idées de comment est-ce qu'ils veulent vivre leur vie. Mais écoutons-les, prenons le temps, puis bâtissons un plan autour d'eux autres que eux autres veulent, comme je mentionnais tout à l'heure. Là. Mais aussi, quand j'ai mentionné le langage, on parle d'un langage de soins toujours. Ayons un langage où on accompagne les personnes en vieillissant, puis qu'on les accompagne à vivre une vie, non à d'être hébergés dans un lit ou dans une bâtisse où ils ne voient plus personne, ne peuvent plus faire rien, puis ne peuvent plus avoir leur banane. C'est simple, la banane, mais c'est une grosse chose quand tu as été indépendant ou interdépendant toute ta vie, que tout d'un coup, tu ne peux pas avoir cette petite chose-là. Ça fait une grosse différence. Puis aussi, le développement puis, du personnel qui travaille dans le domaine, la formation, mais aussi une façon pour les garder à faire leur travail, de s'assurer qu'il y a une comptabilité qui est faite à la fin de la journée, puis mettre dans les pratiques, les normes, que les gens ont besoin de faire telle chose, sinon, c'est quoi qui va arriver? Il n'y a pas de conséquences aux services qui sont pauvres. Il n'y a pas de conséquences quand les gens sont pris avantage d'eux, sont abusés. On n'entend pas que ça va plus loin que être. Il n'y a pas de réprimande, il n'y a pas rien qui est fait parce que la personne ne peut pas défendre son dossier assez bien, normalement.
Merci. Janet, telling mot à toi, last word to you.
The last word to me?
I'm going to give you the last word and just, I'll guide it this way. Let's say a year from now, you're seeing the new Long-Term Care Act come out. Where do you hope we are a year from now when we revisit all of this?
Oh, boy. So a couple of things. I mean, I think it really goes back to we need to signal that older adults are priority and that we start working on a plan, signaling we're working on a plan. We're hearing everyone's coming to the table that's connected to this sector. I am concerned a bit that the long-term care plan is maybe viewed as a solution to all the issues, and it's not, because in acting a new act or a new plan. We also have to ensure that we are giving the stakeholders the resources that they need to execute the plan. I guess that's it.
No, that sounds like a good note. Look, thank you very much to all three of you participating, and thank you to all of you. I also want to say you saw some students get up and leave. That's one of the great things is we're very excited to have this partnership with St. Thomas University and the Center of Best Practices through the McKenna Center, because it's important to connect learning from the way things are now to the incredible work St. Thomas does in a variety of fields. So we're excited, and when we come back in next year and announce our next three challenges, one of them actually is going to be in the area of seniors care, and I'm looking forward to an ongoing partnership marrying the academic excellence of St. Thomas with the policy expertise of the center. So thank you all three, and thank you. I'll give it back to Amber to direct us for the rest of the day.
Okay, thank you so much. We're going to have a stand and stretch. I know students have to get to another class. We may have students join us. So we're going to have a very quick stand and stretch while we prepare for Dr. Sinha to join us on Zoom. Thank you, everyone. We are running a little bit behind. So just to forewarn you, we may cut some of the Q&A at the very end because I know that Laura will be standing between you and lunch. And for some people, that's very important. So it is my pleasure this morning to have two phenomenal internationally recognized individuals who are experts in the area of aging and older adults and gerontology and all of those things and so much more. And so I'm going to introduce Dr. Samir, who is in Toronto and unfortunately was not able to join us this morning, but we are Zooming him in. There he is. I had the pleasure of meeting him through Zoom. At some point we'll get together and we'll meet face to face, but I just want to share that Dr. Samir Sinha is a geriatrician and clinician scientist at the Sinai Health and University Health Network in Toronto. He is a professor of medicine at the University of Toronto. He is a Rhodes Scholar, so you know he's not very bright. An international expert on aging. He has advised on Canada's national dementia strategy and led the creation of the National Long-Term Care Services Standard. He serves on the American Red Cross Scientific Advisory Council and the board of Help Age internationally. Currently, he is a 2024-2025 visiting fellow at Oxford University, once again confirming my previous statement, and an AMS fellow in compassion and AI, exploring digital technologies to support healthy aging. And so Dr. Sinha, if you want to say hi, so we make sure we can all hear you.
Yeah, hello everyone. Good morning.
Excellent. You are good. Thank you very much.
Thank you so much, Amber, and thank you to all of you for inviting me to be part of this this day with you. As you know, it is the International Day of Older Persons. It's National Seniors Day, and so it's really meaningful for me to be able to participate with you in this important dialogue. And just listening in this morning in terms of the Advocates report and really talking about what people in New Brunswick want and need. This is really important that we get this right because we're all aging, and we need to really think about what we want that to look like so we can all age with dignity, confidence, and independence as well. So I have a few things I want to share with you over the next 40 minutes. We're going to really understand that Canadians are clear on where they want to age, but not often enabled enough to do so. We're going to appreciate how aging in the right place needs to begin with the development of age-friendly communities and more innovative and flexible models of community-based and community-led care. And then we're going to understand how New Brunswick's community-based senior sector can be better enabled to support aging in the right place. So often when we have dialogues around aging, sometimes you hear the term tsunami being used. People talk about this demographic tsunami, you know, our aging tsunami that's hitting us. And whenever I hear people use the term tsunami, I immediately start to wonder how much they really appreciate and know about aging. Because if any of you in the room have heard of the baby boom generation and the boomers themselves, we've known about this group for decades. decades now. And not only that, you know, we knew that we were going to age at the level at which we are. And we actually know how much we are going to age in the next 20, 30, 40 years. So if anything, I don't think this is a tsunami. Those things happen instantaneously without warning. I think of this more as an aging glacier. But I also like to think aging from a positive standpoint. I'm a glass half full kind of guy. And so I always like to think about aging really as a triumph. Because if you think about the fact that in 1900, the average life expectancy of a Canadian was 51 years of age. And when we created Medicare in our country back in 1965, the average life expectancy of a Canadian was in our high 60s. Today, it's in our early 80s. And so when we think that we almost doubled our life expectancy over the last 100 years, I think we should think of that as a triumph. And we should think about how blessed we are that so many of us now can expect to live long and healthier lives, and are going to have opportunities to do so many more things as older citizens as well. So when we think about our population right now, we know that this is the year that we're forecasting that Canada will hit 20% of its population being 65 and older. I think the latest stats have said that we're now just pushing 19.5% and we'll soon be at 20%. And that's officially the cutoff where we actually become known as a super age society. And right now, when you think about New Brunswick, New Brunswick has already been super aged since 2021, and certainly now, 23% of the population is already 65 and older, or I like to say 65 and better. And when we think about 10 years out, again, this is a glacier that we're all going to experience. Well, by 2035, it's almost like Canada will catch up to where New Brunswick is, but New Brunswick will keep marching along. More than a quarter of people in New Brunswick will be 65 and older. And in fact, just recently, Newfoundland has now been declared as being 25% of its population 65 and older. So aging in Atlantic Canada is a reality, facing these provinces faster than the rest of Canada for sure. And so the question becomes is how ready are we to meet the moment and really do that? And we heard very clearly from the advocate and from our panelists right before, just what are the challenges? What are the things that we need to really be ready to do this? And we know that with the pandemic and what we saw specifically in our long-term care homes and our overall lens on how our system works, for example, it really started galvanizing where Canadians became very clear about where they wanted to age. Back in 2020, we surveyed thousands of Canadians and found that 91% of Canadians of all ages and close to 100% of Canadians 65 and older said that they plan on supporting themselves to live safely and independently in their own homes for as long as possible. And when we actually look at, I think one of the panels mentioned that I'd be showing some NIA data. I think all of you will have received in French and English our snapshot on aging in Atlantic Canada. And here are just some of the ones from the health and care considerations. Across Atlantic Canada, amongst those 65 and older, 85% want to remain in their own home, and only 5% want to move into a long-term care home. Only 63%, though, say they can access the healthcare they need all or most of the time. Only 53% report that they can access home care reliably, and only 45% can access community support services when they need them. And that's really concerning because, again, when people in New Brunswick and people across Atlantic Canada are very clear on where they want to age, we're not really making it easy for people to do that as we should. And so our experiences also shape our perspectives as well, because for many older Canadians, accessing long-term care usually means having to leave one's own home or community. And we see that especially in provinces where we have significant rural and remote populations. The reality often is that there may not be a home in one's own smaller community, and leaving one's community, being institutionalized, and maybe not being able to receive culturally safe and appropriate care close to family members and friends is unfortunately a reality for many people as well. but there exists a universal desire to age in place amongst most older Canadians and New Brunswickers. So the question is, how can one enable this? Now, I've been using this term aging in the right place. You know, I've heard already this morning people talking about the idea of aging in place, but at the NIA, we like to talk about aging in the right place. And we define that as the process of enabling healthy aging in the most appropriate setting based on an older person's personal preferences, circumstances, and care needs. And not only, as I said, do Canadians overwhelmingly prefer to age and receive care in their own homes and communities for as long as possible, but it's often less expensive too. And so this is one of those rare policy opportunities for politicians, you know, policymakers, but also citizens alike to say, actually, what older people want is actually cheaper for government and our society to deliver. So I've never understood why we don't actually really enable this to happen, as opposed to you know, almost burying our heads in the sand and seeing the challenges grow. So when we think about aging in the right place, well, you know, what are the key things that enable people to do so? And we've really written a full report about this, and the link is attached in this presentation. But we really focus on 4 pillars. Number 1 is we want to promote preventative health and better chronic disease management. The NIA just released a campaign this week called smallstepsbigdifference.ca, which is trying to remind Canadians that up to 45% of cases of dementia can be prevented or delayed by doing 14 things that all of us, you know, can do if we put our minds to it, if you will. And so this is not only the way that you can prevent or delay dementia, but also many other chronic diseases. But for those who are living with chronic disease, there are ways in which we can support better chronic disease management. The next aspect is really strengthening home and community-based care, as well as support for unpaid caregivers. We also want to think about the communities we live in and how do we make them more accessible and create safer living environments. And finally, how do we also think about improving social connections to reduce loneliness and social isolation, just given how significant an issue it remains in our society. When we think about long-term care, and I heard the advocate talk about how there is a goal to create a new long-term care act, as I understood, for New Brunswick. This is a great opportunity. We now have new national long-term care standards. My colleague Laura, who will be speaking right after me, she was on one of the committees, I was on the other, and we really worked together as partners and colleagues to really think about, you know, the physical, the operational, but also what care needs to look like. We also designed key standards, and those are the standards that are being used now to accredit 71% of Canada's long-term care homes. We also did a jurisdictional review that we published at the request of the New Brunswick government and others, saying how far is New Brunswick off currently from actually aligning to those new national standards that over 20,000 Canadians help participate in creating. So we have standards. We actually know what Canadians want, but also one thing that we're trying to do is redefine long-term care, because when people sometimes hear this term, they think, oh, long-term care means warehousing or institutionalizing people in care settings. No, it's not. It's not that. It's about saying that really care should be provided across the continuum. It involves in providing supports for people's basic activities of daily living and their higher order tasks that can be delivered by either paid care providers or unpaid caregivers. It can be delivered in buildings such as long-term care homes, in retirement homes or assisted living facilities, but also in people's own homes and communities. And it can be offered by a number of different providers, for-profit, not-for-profit providers in a variety of locations. And also we need to think about care that's responsive. Someone has a need, we're meeting it. But also, what are the things that we can do to also keep people healthy and well? What are the things we can do to re-able people and support them that way? That's how we think about long-term care and think of it from a much broader lens than just about buildings and places where people receive care. So how do we enable aging in the right place? Well, the challenge is, as many of you know, elder care in Canada is complicated. I think the advocate was saying earlier, when you think about the fact that we even have a care system and that we're actually able to provide care as a society in various ways, like that is commendable. But, it's a bit of a gong show as well. And I think that's what I think a number of people have been remarking this morning, because the challenge is continuing care or long-term care is the largest form of hands-on care that's actually not covered under our Canada Health Act. And remember, let's go back in the time machine to 1965. We created Medicare. We love Medicare. Medicare is something that we are proud to say makes us all Canadian. But the problem is the average age of a Canadian when we created Medicare was 27 years of age. Most people didn't live beyond their late 60s. So we never really thought about long-term care, elder care, continuing care as an essential part. That's why the Canada Health Act enshrines universal coverage of physician services and hospital services, but not prescription drug services, not any forms of long-term care, not even dental care, for example, palliative care, these sorts of things to a certain extent. So all of a sudden you realize that actually what an aging society really needs is actually up to discretion of each province and territory. That's why coverage levels, qualifying criteria, and design standards significantly vary across our provinces and territories, but yet there's a growing value of these services to meet the long-term care needs of our aging populations effectively and sustainably. And we know that the current demand for care is already unprecedented. It's only expected to grow as our population ages, yet the system has been plagued by long-standing systemic vulnerabilities when it comes to its health, human resources, physical design, and redevelopment approaches as well. Now, we need to zoom out a little bit here because, again, here's what's happening in Canada, but how do we compare when we look at ourselves against other countries around the world? So this is a comparison amongst 36 countries, amongst what we call OECD countries. I call this the rich countries club in the world. And really what you see is the average is in the middle, where the average gross domestic product spend is around 1.5%. Canada is a little bit above that, closer to 2%. So yay, we're a little bit above average. But you can see compared to the countries to the far left of your screen, you see that we're spending about half the amount that other countries, certain countries are doing, like Denmark, for example, in providing long-term care services. And these are deliberate choices. These are choices that we make as a society to not spend what other countries could be spending or are spending on the provision of long-term care services. And it's not only that we're not spending a lot, but then also how we're spending our long-term care dollars is very different than, say, other countries. For example, we spend the majority of our long-term care dollars in Canada on caring for people in institutionalized settings, and actually a ridiculous amount of our dollars on caring for people in hospitals, because we don't actually have appropriate numbers of spaces to care for people in their own homes or in long-term care homes. So when you start thinking about, and then we spend the remainder on caring for people in their own homes. That's different than what the average country is spending their long-term care dollars on. Usually it's almost a 50-50 split. And in Denmark, actually, a country I like to highlight, they spend much more on home and community care, far less on the provision of care in long-term care settings. And they have an ALC rate currently of less than 1% compared to Canada's ALC rate of about 15%, mainly because they have a very robust home and community care system. So we also see, remember I said that the jurisdictional spends vary on where you are living in the country. So this is actually a chart showing kind of spending increases in the provision of care, long-term care, both in institutions, but also in homes and communities over a 10-year period. And you can see across Canada, absolutely, all governments are spending more on the provision of long-term care services. Yay. But when you look at where New Brunswick stands, this is highlighted in the red box there, there's been a 21% increase in its spend on care in long-term care settings versus a Canadian average of 80%. When it comes to improving spending on home and community care, it's a 49% increase, but that's compared to 106% on average across the country. So you can see that when it comes to growth and spending, this hasn't been the same priority potentially as it has been in other provinces. And I always say you kind of get what you pay for, because partly, when we're not spending a lot in this space, we're also not really affording people very good wages and support. And so then recruitment and retention of workers in these settings becomes a real problem. And this is actually, again, another cross-country comparison showing that we have significantly less staff, if you will, working in these settings, for example, compared to, again, other countries. And I highlight Canada to the far right versus kind of Denmark towards the left there. So, and then, of course, if we're not spending enough money on supporting people to provide this care and provide cares, policymakers sometimes say, you know what? I don't know what to do. We don't want to put more money into the care system. Just tell families to pick up, and step up more, be a better husband or wife, be a better son or daughter, do more care, drop other things and do this. Okay, well, that's an idea. The challenge is it's not going to be very easy to do, because remember, we're less likely to be living in intergenerational communities and households. We're also having fewer families. When people are having fewer children, it's actually why between now and 2050, again, the glacier, we know what it'll look like in 2050. There'll be 30% fewer close family members available to provide unpaid care. So if we think that we're just going to rely on family members to pick up the slack, we're going to have to ask the remaining family care givers available to improve their productivity by 43% to meet the same current level of unpaid care that family givers are providing today versus from now in 2050. So riddle me that one, right? We cannot, we have to appreciate that our society is evolving, our societies are changing, and it's our time to actually lead. So one thing we put out in 2019 was a conceptual framework supporting the future of long-term care, continuing care provision in Canada. And while this does look like a triangle, or some people, sometimes friends will call this my pyramid scheme, I tell you that there's actually a lot of really good evidence around this. And it really kind of talks about how we can think about people as they age, with different levels of ability, different care settings, different opportunities. And there's a ton of data out there and a ton of great ideas that actually show that they actually work. So we talk about supporting people who are independent in their communities, to how do we support them to stay healthy and independent in their communities longer? This can be the concepts of age-friendly communities, home sharing, co-housing models, home accessibility and modification programs. The one amazing program that exists for our veterans is the Veterans Independence Program, which does an incredible amount of things, including supporting people with things like yard work, for example, that can make an enormous difference. Laundry, housekeeping, these sorts of things. And when we think about age-friendly communities, they're communities that the World Health Organization defines as ones that recognize, promote, respects, anticipates, and respects flexibly and responds flexibly to aging-related needs and preferences. And this is what we talk about when we say about age-friendly cities and communities. It's one that thinks about all of these kind of social determinants of aging well. How do we improve inclusion and participation, the housing and transportation needs, but also the community supports and health services that really allow people to age well and independently as well. For people who might need more supports, we talk about the importance of community transportation services, preventative home visits and reablement programs, NORCs, for example, and also community paramedicine programs. And this is actually where you can even think about New Brunswick's Nursing Homes Without Walls program, depending on how equipped and the services it does. This is where you can think about either supporting moderately intensive services or more high intensity services. But I just want to quickly mention community paramedicine programs, because when I was talking with the advocates team, for example, they were really intrigued with something that we've really helped lead the development of in other parts across the country. This is a picture of Siobhan, one of the community paramedics that I work with here in Toronto, and the Toronto Star did a beautiful feature on the team and their work, and they actually called it Heels on Wheels, if you will. We often think about paramedics as simply being folks who just you call, they haul. But paramedics are incredibly skilled. They're embedded in almost every single community across the country. And they very much don't like to see people in urgent and emergent situations. And they often see some of our most vulnerable citizens on a regular basis, well before they ever end up in emergency department. Because one of the most frequent reasons that paramedics get called, number one, is the majority of the calls they get are for older people, and the majority of the calls they get from older people are for what they call lift assists. You know, I've fallen and I can't get up. And so we know that community paramedic services, when you actually implement them, they can have incredible outcomes. In this case, in Renfrew County, they were able to cut 911 calls in half by providing weekly paramedic visits for those individuals who are long-term care eligible, for example. And over time, community paramedic programs have been developed based on local needs and service gaps. And they can vary in scope and services provided, service settings, clients served, and the types of outcomes achieved. The three types of models that have emerged, over time, one that I love is called CREMS, or community referrals by EMS. Paramedics might see an older person who may have fallen. They say, look, you're not getting any home care. You might benefit from an occupational therapy home safety investment, or maybe a little bit of help around the house. Could I make a referral directly for you to the local home care service? Last year in Toronto, they made 10,000 referrals, and we published a paper showing this has actually decreased future 911 calls by 10%. Preventative home visit models, CP at home, is a model where they actually look at their data and they identify people who are calling frequently for non-urgent reasons. What we've done is, with this team of community paramedics in Toronto, I've trained them all to do comprehensive geriatric assessments where they will actually meet that person and say, hey, you've been calling a number of times. Maybe we can do a little bit more of a sit down and a chat, figure out things together. And this is where they're connecting people to primary care providers. They're getting them connected with home care, Meals on Wheels, and a whole bunch of just really cool things, which has shown it is an incredible program to decrease 911 calls, but also transports to emergency departments. And then there's a really cool initiative called CP at Clinic, where they actually have paramedics doing wellness clinics in seniors' buildings, for example, blood pressure checks, diabetes checks, that really help people stay on top of chronic diseases and help prevent crises from getting worse. And then there are other unique models depending on local needs. And overall, these programs have demonstrated their ability to be cost-effective ways at improving access to care and better outcomes. So finally, when we think about people who might be eligible for nursing homes and care in nursing homes, there again are models of care that can support intensive people with intensive needs, models to support unpaid caregivers, interprofessional and home-based primary care models, enhanced adult day program models, supporting housing models. And again, I mentioned Nursing Home Without Walls, which I know many people in the room know because it was a New Brunswick creation. And then there's also really cool models that provide nursing home alternative care models, like the PACE model based in the United States. And so we have to also realize that our realities need to be respected, because while we have 2,000 long-term care homes across the country caring for over 200,000 Canadians, it's predicted that we would need 200,000 new beds to be built by 2035 to meet the anticipated and growing long-term care needs of Canada's rapidly aging population. And right now we have over 70,000 Canadians who are currently waiting to access care in a long-term care home. And then the challenge is that when you look at the typical care home, they're large, big institutions, and small and remote communities do not often have the scale to operate traditional large long-term care homes. And so many Canadian jurisdictions have now been experimenting with the idea of small long-term care home models, and often with limited success for decades. But now New Brunswick has the opportunity to do this. Quebec has been building these, what they call Maisons des Années, now as their new pivot, for example. The Alberta government have been working with them to introduce a new program to build small long-term care homes that can actually serve smaller rural and remote communities much better as well. And it's a way to help people age in their communities. But again, it's only one example of what one can do as well. we have to remember as well that we have choices and options, because waiting waiting in hospital to go elsewhere, being an ALC person, these are Ontario numbers. It's $750 a day to the healthcare system. Living in a long-term care home in Ontario costs about $200 a day, and home care in Ontario for a long-term care equivalent person costs $103 a day. So you don't have to be, a mathematical genius to realize, where you can actually get the most bang for your buck. And this is what Denmark did. Denmark did the math decades ago, and then they actually started implementing a model where they were going to say, we're going to spend the majority of our dollars caring for Danes in their own homes because that's where they want to be. And they actually ended up avoiding building any new long-term care beds over 2 decades, and actually saw the closure of thousands of hospital beds by strategically investing more in their home and community care services. And we know now that medical and technological advancements are allowing more people to be able to age and receive complex care in their own homes. So more over time, we are better able to do this more than ever. And we actually started putting more money into home and community care when I was a seniors lead in Ontario. And this helps demonstrate in this chart here. The purple bars show people who are long-term care eligible and receiving care in their own homes, versus the blue bars showing people who are 75 and older who are living in our long-term care homes. And while we built no new beds over this 10-year period, you could see that we eventually, by putting more money into our home and community care system, we're able to support more nursing home eligible individuals to be living in their own homes than actually existed in our own long-term care homes in Ontario. So when you actually put more money into the system, the way Denmark has, then you actually decrease the demand for long-term care beds as well. So very quickly, the US PACE model of care, or the Program for All-Inclusive Care for the Elderly, is a model that they created that basically now runs across 31 states, across 260 programs for about 51,000 people. And it's an alternative to care in a long-term care home or nursing home. So it's different, much different to nursing home without walls. It serves people who are 55 and older. They're certified as needing long-term care, and they're able to live safely in the community with PACE services at the time of enrollment. And they provide a whole bundle of care. They're responsible for providing your medical care. They're providing your home and community care. They're making sure that you've got your transportation and all your other needs met, basically. And these organizations are given the same amount of money that they would get if they cared for you in a long-term care home. And these PACE programs have basically demonstrated their ability to decrease ED visits, less hospitalizations, less rehospitalizations. And when people were admitted into this program, they found that after 3 years of enrollment, only 15% ended up living in a long-term care home, even though they were all eligible to live in a long-term care home at the time of enrollment. And what was most important too is that caregivers experienced reduced family caregiver burden and distress as well. So now imagine you take Nursing Home Without Walls, you throw in a bit of community paramedicine, you give a new funding model, because again, there are many people in New Brunswick who are going to need long-term care, and I don't know if you're going to be able to build all the beds you need as quickly as you might hope you will. And Laura can tell you in Ontario, there was a goal in 2018 to build 60,000 new and redeveloped beds in Ontario, and they've only built 5,000 to date. And that was a commitment made in 2018. So yeah. So imagine that New Brunswick started issuing virtual nursing home bed licenses, paying the same per diem to care for continuing care eligible persons in their own homes. And a virtual long-term care at home program would be responsible for coordinating and providing enrollees access to community support services like Meals on Wheels, transportation, adult day programs, or friendly visiting services, their home care services as well, primary care, linking them to primary care providers, and making sure they have the primary care needs they want. And remember, we talked about community paramedicine. It's a service that can provide 24-hour remote patient monitoring capabilities and other supports as well. These are all things that we actually have available. And imagine now you knit them together and what you could actually do in communities that say, yeah, we could come together and do this. Rarely do we enable community and empower community to do these things, but this is something that's worked wonders in the U.S. and something that I think could easily work in any jurisdiction in Canada as well. So I leave you with this, that we can enable aging in the right place. And really, it requires a shift in traditional thinking, but we can create alternative housing options and community care solutions that better promote independence, dignity, and respect in New Brunswick and across Canada. And innovating continuing care approaches can only succeed through collaborations and partnership, and can ensure that the sustainability of our healthcare systems for years to come. So thank you very much, and best of luck for the rest of your discussions for this day. Thank you.
Thank you so much, Dr. Sinha. It's a pleasure to have you. We wish you were here with us, but we know we look forward to a time where we're able to bring you to Fredericton and to New Brunswick, and to share your expertise even further. So thank you so much.
Thanks for having me. Take care, everyone.
So a lot to think about there. Next, I'm going to welcome Laura Tamlin-Watts. She is the CEO of CanAge, Canada's National Seniors Advocacy Organization, a lawyer and internationally recognized expert on aging. She teaches law and aging at the University of Toronto. Her #1 bestseller, which I believe a few of you have today, Let's Talk About Aging Parents, has been released in 9 languages in 12 countries. And Laura provides her expert testimony to governments worldwide, from Canada to Australia, and recently shared her insights at the United Nations and the Vatican. She chairs on and sits on numerous boards, including the Canadian Investment Regulatory Organization and Age Well. Laura and her husband, Michael, CEO of Rakin Kabuko, I have a Kabuko, so I know this well, balance advocacy and raising 3 children and caring for aging parents. So I welcome you, Laura. Thank you so much for joining us. Yeah. Perfect.
Thanks so much. Merci. Bienvenue à tous. Iset, my family originally comes from Elgin, New Brunswick. Do you guys know Elgin? Not even Port Elgin. Elgin, like the little one, right? I'm a Goddard originally. Yeah, I know. There's lousy Goddards are everywhere. My grandfather's name was Laurence Frédéric Le Baron Saint-Denis Goddard, and we called him Deke, and no one knows why. Merci vraiment, bienvenue. C'est vraiment une journée extraordinaire ici. Like, when do you ever get the minister sitting here, the advocate putting this on? And I want to tell you, I turned down the United Nations to come here today. I did, actually, really. It's the International Day of Older Persons globally as well. And also it's the United States. I'm a little cranky with the United States right now. I think I'm not the only person that's a little bit cranky. So what I want to talk to you about is stuff we can do that we know works, that doesn't cost a lot. I know, right? Because there are things that are really well proven. But I want to first of all stop and say, I hope you know what a treasure your advocate is. And I'd like to ask for a round of applause for the work that him and his team are doing. Because when it comes to things like measurements and reports, unless you have something that says actually how it's going, it doesn't matter what we do. And it's easy to lose sight of the fact that this is a multifaceted issue, right? Our incredible and august panel, I mean, come on, who was sitting up here, right? Fantastic. Thank you for all the work that you've done. It's extraordinary. And when we're hearing it's multifaceted, it's because people and systems have to work together, right? We know that. But there's ways of thinking about it that can help us get our head around it. I wish the question that was asked of each of them, what can you do? What would be the thing that you would do? And my free, easy, and already required thing to do, ministers, just make a note, just saying she's got a pen. Voilà, c'est tout simple en fait. We already do something called the GBA plus analysis. It's the gender-based plus analysis, but we don't do a great job of it. And since it was created in 1996, there has been the obligation to take age as part of our thinking, a lens-based approach. but we actually mostly don't. What happens is people say, oh, over 65, under 65, 19 or under, and that's what we do. So I would say we have a lens methodology. You can use it and then tell people what you're thinking about, which is part of what we heard, and let them learn how to think with that GBA plus analysis about age. There's also 5 things that you need to do to live well, both individually, in your families, and the community. And really there's 5. The first is don't fall. Don't fall. You know what? The chances of me falling off this, 50-50, okay? Don't fall. And when I say don't fall, I really mean don't fall, right? Don't fall. If you fall as an older person, right, and you break the hip, you hurt yourself in any other way, your chances of dying in 1 year, 24%. Oh, qu'est-ce que je... Merci. Oh, okay, don't fall. And this is what happens. Merci, c'est trop gentil. I for sure would have slipped on that. Your chances of dying in 1 year is 24%. And we've just got new statistics. If you manage not to die in the first year, félicitations, right? Your chances of dying in the second year have just increased from 40% to almost 50%. And if you manage not to die, bravo, your chances of ever walking normally again is less than 20%. Number 1, don't fall. Number 2, stay connected, okay? If we're talking about things to do to reduce dementia, things to make sure people have purpose, whatever that is that gives purpose, if we lose that, your chances of dementia skyrocket by 1/3. The cost to government go up dramatically. And really, that's where the cost of social systems, and that's where the bananas come in. Like, that is the stuff. If you become disconnected from whatever it is that is meaningful to you and your community, that's where we see it. In fact, the highest degree of suicidality in this country are men who are single between 71 and 74, and you know that, between 71 and 74, highest suicidality, and it's not because of health, it's because of loss of connection. Number 1, don't fall. Number 2, stay connected. Number 3, Minister for Health, Monsieur, voilà, on est où exact? Voilà, merci, Monsieur. The most important thing that you can do is fund all NACI recommended vaccines. It's just that simple. And New Brunswick's got a long way to go in funding all NACI recommended vaccines. The cheapest, most effective thing you can do. The shingles vaccine. Anyone ever had shingles here? Do you know you can get shingles in your eyes? You do. It's one of the causes of blindness, incredibly painful. One of the reasons we have massive opioid addiction problems, shingles. The rest of Atlantic provinces can cover it. Almost everyone else in the country covers it. New Brunswick does not cover the shingles vaccine. Did you know that there's a new study that came out of Wales that said the most effective single thing you can do, except, eat right and exercise, besides eat right and exercise, that there's a 20% reduction of protection of dementia by getting your Shingrix vaccine. It's research out of Wales. It's absolutely fantastic and is significantly protective of heart health, lung health, and stroke. You also don't get shingles. 20% reduction is protective against dementia. So even if you don't care so much about shingles, most people care about dementia. Number 1, don't fall. Number 2, stay connected. Number 3, fund all NACI recommended vaccines and make them easy for people to get. Number 4, make sure that you have a good understanding of what your community has. It really is. And that's where the recommendation from the advocate, particularly about integrating the not-for-profit sector, community engagement sector, that's where that magic is. And I come over from my community in Sandy Cove, Nova Scotia. We have 71 people in Sandy Cove, Nova Scotia. We're down 1. We have 3 nonagenarians, but the baby is about to be born. So we're going to have to change the sign because we're going to be back to 72 anytime now. And when I say, look, the hospital's at Digby, but don't worry, it's not open. Right? There's no point going, that's not open. So when you think about what our community has, what we have are people who care. That's what it is. We have, someone's going to bring you a pie at any moment at my community, right? But there's no way to get to town or to Yarmouth or to anywhere else. There's no transportation. So community mapping of people and organizations and systems, that's what really, really matters. And the last thing to do is, and you couldn't have said it better, unless you are measuring it, it doesn't matter anyway. But the piece that I would add on to that is infused throughout your report, which is you need to have easily accessible information and transparency in what you measure. If you need to get a freedom of information request to find something out, it doesn't matter if you measure it because nobody will know about it anyway. So those are my 5 things. So this is one of the ways that we think about these issues. I need a mnemonic because I've hit my middle years and my memory and your eyes are kind of in a thing. So this is how we call it in English. And we, of course, have it en français si vous voulez aussi. C'est aucun problème. And so we've categorized the issues dealing with aging in this way. There's lots of ways to talk about it. But what I would say is when you're doing that GBA plus analysis, right? Check to see if you've thought of these things. And when you'll see under C, we don't have long-term care in the health category. And it's because it's how people live and when they're connected. Samir was talking about the reduction in the assumptions that people have when it comes to aging and community. Here's my little quick list for you. When you were thinking of any policy, any number, qualification, strategy, if it's persons with cognitive impairments, disabilities, if it's housing, if it's whatever it is, our healthcare system, CPP, ask one simple question before you do anything else. What was the average age of death when this was implemented? Just that, just ask one thing. CPP, age 65? We should be proud of it. It's good. Average age of death? 67. Great. So you worked really hard. I don't know, went fishing for like a year or two, right? And then dropped dead suddenly. You weren't sick. Average age of death when we put in our modern healthcare system, right? The federal health legislation? 76. Every single one of those top 10 things that killed you when our health legislation came in is now a chronic condition, which is great, except it's not. And Canada is actually not doing that well. Samir was a bit nice he showed you the pretty OECD statistics. Here's the one that's not so pretty. This country is the only OECD country that does not have a national senior strategy, and most provinces and territories also don't. Now, you do have a wonderful advisory committee. I will help. Lots of us will help. For sure. You heard me. I will help. I will volunteer my time because New Brunswick is unique in this country, in my view, because you are so fast, nimble, agile, and practical. And so when I go and I talk at the United Nations or other places, I brag about what's happening in New Brunswick, but mostly I brag about the ability to think solution-focused and community-based, and that's the magic of this province, in my respectful view. If you click through this, when you click through this, you'll see, and I talk a little bit about policy and advocacy, and just for clarity, the lawyer in me wants to give you a definition. I'm talking about when we're thinking of policy, I'm thinking about how you do a thing that helps a bunch of people, right? What's a thing that you're doing? That's how I mean policy. And when I'm talking about advocacy, I'm usually talking about the levers. So there's the lever that when you can do something, like my community can get together and decide that we're going to bring, once a week shuttle service, someone's going to volunteer to bring people into Digby for grocery shopping. We can do that. We can do it ourselves. We don't need to persuade someone else. But if we want to make that into a program, then I need to persuade somebody else to help me do that. Talk about third-party advocacy. So when I'm thinking about how some of these things connect, it's telling that story. And the story of the banana is a perfect example, right? The story of people and communities are a perfect example, but there can be great stories because they have to integrate. And this report talks about the importance of not just everything happening by government and costing a lot of money. That doesn't work. But also, I don't think it's what people want, right? They actually don't want it. They want to make solutions themselves. And sometimes they want governments reasonably to help bring them in. So when I'm looking at these issues, I want to ask you to think about three things. You meet people where they are. And if that means the ministers in the front, they're meeting you here, but it also means that they can't do everything. We don't have unlimited budgets. It's not possible to do everything. So understand if it's a community member, a family member, a person who's weeping in long-term care. Over the course of this morning, I've had a person tell me that their older brother has just been diagnosed with dementia, a friend of mine whose husband just had a cardiac incident, and that somebody has just fallen. And that, by the way, was before the morning break. Does anyone here have conversations and text messages like that show up at their house? Yeah, it's all of us together. So when we meet people where we are, we need to understand there's a lot of worry. That's one of the reasons I wrote the book. Figure out their levers. Not everyone can do everything. So I can't say, we should do this at a federal level in a provincial area. I can't say to a municipal person, we should be fixing this highway. It's not what they do. Figure out who can do what and what their mandates and levers are, whether it's community-based, whether it's government, and then be your solution. So if we do fund, for instance, the shingles vaccine, it's helpful to the dementia community. And that means you can bring together communities that don't necessarily work. If you go onto our website, we've organized sort of these policy things in very easy to open. So if you click on each one of these letters, you'll see as an example other key issues, and you click on those, and there are literally recommendations that you can take. And we measure everything we do because it's good. We're about to drop our new annual vaccine report card. And we looked at measuring three things: funding, access, and awareness. And I offer it not just because vaccines are important, they are, but also how you can look at an issue and think about how do you tell the story, how do you measure, and how do you do it in a way that's useful. So it's actually going to be worse this year, just to let you know. This is before. If you're looking at what matters when you're looking at the comparisons, what I can tell you is between now and then, all the other Atlantic provinces have gotten much better, and New Brunswick has gotten a little bit better. And when you're comparing types of measure what you care about, you'll see here we measured funding, access, and awareness. And I just wanted to share one example. British Columbia had great material about awareness on this issue. Everywhere you went, you could find fantastic information about vaccines, why you should get vaccines, how important it is for you, your family, and your community. People in BC have all the vaccine information they could possibly get, except they don't fund them and you can't get them. Great. Ontario, by contrast, had good funding, pretty good awareness, but terrible access. You couldn't get it. So when I'm saying measure what you care about, figure out not just those basic, how many staff members work in long-term care. But when you're looking at some of the recommendations about quality of life and CI and so on, measure what your community cares about. Measure the bananas. Don't forget, right? It's Truth and Reconciliation Day every day, and every day should be Truth and Reconciliation Day. And I want to say that when I'm talking about the statistics I gave you, the broad is the enemy of the accurate. The broad is the enemy of the accurate. Yes, it's true, Samir. The average lifespan in Canada depends where you are, 82.5 to 84 years old. The average lifespan of an Indigenous Canadian is about 63. So if I was only counting things in my GBA plus analysis, of people over the age of 65 and how well they're doing, and the average age of death for an Indigenous Canadian is 63, not only am I getting bad data, not only am I excluding an entire population, I'm using a colonial approach to a population problem. Find out what that community needs, what your community needs. So always figure out who your call-outs are because they matter. Poorest population in Canada, besides Indigenous people, is women who have been married, who are widowed or divorced in this country. But we can't measure it well because we use market basket measures that look at what an average, I don't even know what that is, but an average family in their 30s, early 40s with young kids needs. And in that market basket measure, hiding seniors' poverty, and particularly hiding women and gender inequality in poverty, the basket of stuff that's there doesn't mean that those are the things that population needs. I mean, baby food is included in the market basket measure. Care isn't. Medications aren't. So if you're looking at what the cost of things that older populations need, they are both more expensive and not reflected. And this is entrenched poverty. So yes, look at the numbers where we say we're doing well, with our financial well-being in Canada. And then ask if that older person can afford to sell their house, because the only thing keeping there, despite the leaky roof, is that they can defer their tax. And there's no other place to move. There's no other place to move. So when we're looking at different things, also, I have here examples. I know there's been some positive changes in this province around the new pneumonia vaccine, which is great. But it's important to remember that when you're thinking about it, don't think about this is my line on immunization. Remember, it connects to hospitals. It connects to communities. Remember we said we'd never forget COVID? It connects to the economic drivers. And this is at a time where Canada, and Atlantic Canada in particular, is at a critical labor shortage. We already need Canadians to work 7 more years than they are. And I'm tired now at 54, but 7 more years. And that connects to the caregiving issue. So what do I say we need to do in this community? Have conversations with the commerce, have conversations with the BIA, have conversations with business about changing caregiving leave to not just kids, but understanding that we have intergenerational care needs. There's a well-known phrase that there are only 4 kinds of people: those who are caregivers, those who have been caregivers, those that will be caregivers, and those that need care. And that's true, except we are no longer that sandwich generation. We are a club sandwich. We're 6 generations right now, 5 in the workforce. And you're likely to be a caregiver, look down the pipe and think, I'm going to also be another caregiver. Look backwards and think, I have been a caregiver. And also, I'm probably myself needing care. And that's the difference in our thinking. All at a time, and I'm a Gen X generation, so we're at the hourglass bit. When I said, ask what the assumptions of age of death were, it's also important to remember what were the population norms. Samir talked a little bit about that 30% reduction. What I can add to that is by saying 75% of all care is provided free by, and I'll use the term family in its broadest context, community. It's free, quote, except it's not free. It's women's money. It's the money of people dropping in and out. It's the money of businesses that are being lost because they don't have the systems. It's not free at all. And 75% of it, it's predicated on that. And when we created those ideas around our healthcare system, we did it at a time where I hate this term, the dependency ratio. Isn't it an awful term? I know, can't stand it, but everyone uses it. The dependency ratio of the presumption when our healthcare systems in Canada were brought into force. The dependency ratio assumed that for one older person, there would be 4 to 6 younger people to provide that free care. The assumption was it would be one older person getting care from 4 to 6 younger people. We flipped that last year. It is now for every 4 to 6 older people, we have one person to provide that, quote, free care. And so that means we can't do it. Those presumptions don't work anymore. And so we need to be thinking about how to communicate differently, how to communicate an integrated pattern. Just to give you a sense, getting that new pneumonia vaccine does this, okay? The new vaccine does this. Every single pneumonia case that's prevented staffs that. These are astonishing numbers. You want to know what's cheap? Vaccines are cheap. You know what's expensive? Acute care in hospitals. And the money that you are also pulling out of the systems because someone has to take them to hospital. And in my community, that's a day trip. It's not a trip around the corner. When you're looking at it, if you're looking at what things cost, if you have somebody with pneumonia in hospital for 6 to 10 days, afterwards, they're going to have that amount of intensive care and then a 25% chance of going into long-term care afterwards. It's just the numbers are huge. The pneumonia vaccine is cheap. When we're thinking about a single case, these are the numbers. Every single case of prevented pneumonia of an older person in this province will fund a year of home care for a healthy senior. A single vaccine. Minister, just saying. We're talking about dementia here, and the report on dementia is really important, okay? It's really important. The average amount of time it takes for symptoms of cognitive impairment of an aging population to show up tends to be 10 to 7 years before any diagnosis. So it's about a decade we're starting to get symptoms before. That means a massive, massive concern around things like financial abuse. It also means things like falls. It also means things like social isolation. It also means things like forgetting to get your vaccines. It also means that you get disconnected from your community. And it also means that you stop being measured in a good way. And you start being measured as a sick person. And you're not actually a disabled person because there's not the connections though it should be, because of course, cognitive impairment is a disability issue covered under the UN Convention of the Rights of Persons with Disability. By the way, thank you for your global leadership in that issue. So I thought I would end on just a really pragmatic note. When we're coming up with solutions, and there's lots that are inexpensive, easy to do, and you can measure them in existing ways, this is my practical slide. It's an ugly slide, and I do it because you can take a picture of it. It's really simple. If you're going to come to somebody, this is how you do it. And when I talk about that as a practical solution, you need to make sure it's a solution that's co-created with the people. This is, bless their hearts, a solution to avoid falls. Remember I said, number one, don't fall? Oh, so nice. The young engineering students came up with this idea of inflatable hip airbags. And my favorite was after they were rolled out and oddly not taken up. I'll never forget this incredibly stylish woman who was 95 years old and said, quite frankly, I would rather fall and die than wear that. And I was kind of like, yeah, I'm kind of with you. So when you're trying to figure out the solutions, it's so critically important to have the people for whom the solutions are about. Nothing about us without us has a really practical reality about how to do it. Usually I do this. I talk to you about X, about how many members you are and how you live and whatever. Just get to the point, right? and figure out what it looks like. Have costed it out. And if you can't cost it out, find somebody else who can. And when you're thinking about cost, remember, there's the cost that we talk about up front, like how many dollars something costs. And then there's the cost to our community and the cost to our moral center. And to me, it was incredibly, incredibly helpful. I was sitting in the front with my computer taking notes, because what this also shows is there's not just a cost, but the opportunity to learn from each other. So I'm hoping that I get a chance to learn from the rest of this group and this community. But remember, the last 5 things. Number 1, what was it? Don't fall. Number 2, number 3, get all your vaccinations. Number 4, know your community. And number 5, measure what you care about and make it easily searchable. Thanks, everyone. Thank you.
So we have some time left over. We sped up and now we have a little bit of time, and we have an opportunity for some Q&A with Laura. or the advocate. I'm not sure that he's in the room right now, but Laura's here. Unfortunately, Samir is not. We also have, of course, Ken. We have Janet. Are you still here? You got to teach. There's Janet. And do we have Danny? Danny's in the back. So we have these experts with us, and if you have a question for any of these people, you're most welcome. I have some colleagues, and we'll grab some mics that are being put together for us in the back, and we'll just we'll go around. So if anyone has any questions, now is your opportunity to ask all these brilliant minds anything that you might have. Terrifying moment where the Ferris Bueller is going on. So let someone has something. If not, I have. Come on, extroverts. You're my team. There we go.
Hello, I'm Joan McFarland. I look a little different today because last week I got hit by a truck and I was crossing by bicycle along Lincoln Road. Anyway, I've been working on this area for quite a while. So one thing I'm not hearing as much about as I would like to hear about here is I would like to be hearing about the cost to seniors of going into long-term care. That's a big issue. It makes a big difference how much we have to pay. And in New Brunswick, if you go into a nursing home, there is a cap on nursing home rates. So there's an amount that you can pay, and you wouldn't have to pay above that. And that's universal. However, and other types of care, special care homes, there's no maximum amount that you can pay. There's no, not at all. So that frightens people, seniors, looking at their future. So that is something that really has to stop. Really has to be solved. Okay, just one other thing I'm noting is that I hear talk about a long-term care plan, that we're getting a long-term care plan. I think there's a difference between, I mean, I'm hearing it on the media and various things. I think there's a difference between a long-term care plan and long-term care act. I think when you're talking about the long-term care plan, you're talking about how to solve the ALC, the alternate level of care problem with the hospital. And I think when you're talking about a plan, that's what you seem to be talking about. But we also need a change in the Long-Term Care Act, because only with a change in the Long-Term Care Act would you be able to put a cap on these other rates, the rates for special care homes or for home care. Because at the moment, we only have a long-term nursing home act, which only applies to nursing homes. So we need a long-term care act that applies to all kinds of long-term care. Thank you.
Thanks. I'll come at, it was really such a rich conversation, and talk about commitment. I'm so sorry, and I'm staggered that you're here, but thank you for being here. I said don't fall. I didn't say don't be hit by a truck. I'm so sorry that happened to you. Let me take it into 3 parts. The first is there's what they say things cost, and then there's what things really cost. Right? Anyone here resonate with that? Right. So let me parse the piece that you talked about, sort of long-term care, nursing home, CAPS, and so on, which you can find in the report and is something that social development and health have been working, I think, really carefully on, and I think extremely earnestly on. First of all, things are getting a lot more expensive. I went shopping the other day and I was the person staring in front of the dairy thing saying, sorry, $9 for butter. Like, have I lost my mind? Like, what, So when we think about the cost of things, it's important to remember first that the costs seem to be raising on some things in an almost unmitigated fashion. They're just exponential costs. The second thing is that how we measure what things cost and who needs them is not connected. So this is something you see as well, some of the financial conversations that are happening at this provincial level and the federal level need to happen, because if we're going to measure things by the CRA status and so on, we need to understand that this federal government has been, quote, fixing the market basket measure and fixing the consumer price index. Well, sir, I think you've been doing it since 1970-ish, that you've been having the conversations about what things say they cost and how we calculate them. And so I think there's an opportunity for New Brunswickers to actually think about the CRA costs and the qualifications. There's an interim step where you might look at what the New Brunswick costs are and see if community-based organizations can help to play a linking role and fund those community-based organizations, because they're already mostly doing it anyway. They're already those Meals on Wheels. They're already helping on those volunteers. So is there a thing that we can do where we actually measure the reality of what things cost for people and communities at a provincial level, understanding that the feds are going to take their time? I think the answer is yes. Number 2, it's important, particularly when we're having kind of congregate housing, and I'm going to use that term with care. So whether it's the retirement home or that 24/7 care that you get in that more traditional long-term care nursing home or something in between, the housing plus care, the standards of what is given has to be measured better. And I won't say about this province, but let me pick apart Ontario because it's just fun to do. And one of the things they were doing, the retirement homes in Ontario, which have literally become a for-profit parallel model to the public long-term care. That's what's happened without the legislation to allow it, but it's been happening. You get podiatry care, and it's being charged at the clinical level for a podiatrist, but what it is kind of a bad spa treatment. Right? So getting those quality metrics of what's being provided and what can be provided is important. There's a consumer issue here about the cost of care that I think is really important, what you're buying and what you're getting. Number 3, do you know how much it costs for 24/7 care for somebody to come into your home who has about a 6-week training course? Put your hand up when you think it's right. Annually, under $30,000 a year. 30,000 to 75,000, 75 to 100,000. Ministers, you're exempt from this. 100,000 to 150,000, 150,000 to 200,000, more than 200,000, almost 300,000. Yeah. I don't know about you, but I don't know a lot of people that have an extra $250,000 to pay for somebody with a 6-week plus to come and provide care. So when I see the information about everyone wants to age at place, of course you want to age at place. Yeah, me too. Except that sometimes it makes you fall because the built environment isn't set up right. Sometimes it keeps you socially isolated and you lose purpose because you're not connected with your community. That's number 4, I skipped there, right? So when you're thinking about aging, you have to think about a community, whole community level. And that's where the age-friendly stuff can come in really well. When we're thinking about the cost of living, we really have some great opportunities, like the NORC model, the naturally occurring retirement communities. If you're in my little community in Sandy Cove, you know what would be really helpful? Send one support worker to do the 50 people that need the help, in some coordinated fashion, right? Because otherwise it's one person who comes in and does 5 minutes of care and then drives 20 minutes back. And anyone else have something like that in theirs? And you think, what about all the other people? Wouldn't it be helpful if we worked with the scheduling agencies to just have somebody have 2 days of nonstop appointments and chiropody and vaccinations and the pharmacy outreach programs and the mobile diagnostic programs? So if you're working with your communities, you can say what works for you, and they'll tell you, you know what? It would be great if on Wednesdays, all the home care got done. It would be great if the outreach paramedic program, which are, by the way, great, and something Samir didn't say, is that a lot of those programs were actually created in New Brunswick and then exported to Ontario and are now coming back to New Brunswick. So a lot of those innovations are there, right? So number one, figure out what actually the real costs are and find real ways to get around that consumer price index, market basket measure, like find out what it really is and see if your community-based organizations can help you bridge that. Number two, the reality of aging wherever you want, we're gonna need to have better resource allocation to do it because there are not gonna be more resources, right? Just reality. And number three, make sure you be upfront with people about what you really need and what are creative ways to do it. And having those community conversations, I think, are important. But people aren't made of money in governments either. So prevention is the key. Prevention is the key. Get one vaccine, save an entire home care for an entire year. There are some things that just make sense.
Hello.
Yeah,
Sorry.
voilà, ça arrive. Voilà.
When the CP clinic was mentioned earlier, the paramedic clinic, is that specific to, I know you just said that a lot of programs were created here in New Brunswick and sent back to Ontario. Is that one of the programs or is that here? Because I do know that they have training specific for paramedics but if that it'd be something for somebody come to the house of community members of New Brunswick.
So the paramedic programs are exciting. So first of all, you had to get the college, the professionals of paramedics, and ask them, what do you need to do for your professional training? Because a lot of paramedics joined up because they get in a thing, they go really fast, they stabilize you, they staunch the flow of blood, they strap you to the board, and they wing you right back to the completely open, extremely well-resourced hospital, which is 10 minutes away. Come on, I watch those shows too. They look great. Okay. But what actually paramedics have said is if you give us a little bit of time in our communities, and many paramedics are coming from some communities and they know them really well, but you need to give us different credentials. You need to train us differently because we are meant to go, not really ask many questions, staunch the flow, strap you, and drive you fast. So help us with creating some micro-credentials. A thing you can do, by the way, is make those micro-credentials free or free and easy at least, or at least easy for people to step up because palliative care paramedics exist, but it's the almost opposite for what they're trained for originally. So they need to be given that help and support and they want it. Diagnostic paramedic programs where you come with x-rays machines, ultrasounds, now frankly MRIs, like it's amazing, CAT scans, all can be done in a mobile RV, but you need to train them to do it. They are pilot programs. The one that Samir was just talking about has just been picked up and spread in Ontario. But again, often people don't realize that those basic programs came from near the border with Quebec. That's like the Edmundston area is where those programs originated. But we have to stop being a province and a country of pilots and start being a country of programs. So I hope that helps you a little bit.
Oh, hello. It really does. Like I oversee my whole community of Kingsclear. So there's times where we have seniors and we're not 24/7, right? Because I don't run the home care. I not the home care building. I just do the home care, community care. So there's times where we have community members that need 24/7 care, but we accommodate the families as much as we can. So there's times where there's one person, we've called the ambulance for this person about 30 times, but it was a cardiac thing, but he couldn't acknowledge that because he had dementia. So eventually, they got to know him pretty well. And then the doctors figure out the right diagnostics, fixed him up. And eventually we had to put him in the seniors home eventually, just because he just outgrew the program type of thing. But it was nice when and I'm not saying all paramedics can be rude, but some can be very rude. And I challenge them and they know it. So, but when they are nice and they're friendly and they offer supports like that, and they say, call us anytime, we'll come and check on you, blah, blah, blah. I love that.
And I think what's really important, I'm going to reframe rude as efficient, because you're paying them to show up and fix it and go, right? It's very different than paying them to do a type of a training and service. And I really understand that there's a great need for it. The other thing I would say is work with your local pharmacists. Talk about a treasure in your community, right? And even if you can't get someone to go to a healthcare provider, one of my favorite things was done by the UK. Talk about something that's free and easy and has evaluation. The United Kingdom asked, whatever, pharmacists to put, the little bag that your prescription's from, and then they staple it, the little bag, right? On every pharmacist little bag, for every prescription you get, there is, don't forget your flu shot, or have you booked your flu shot? Every single one from, I think it's the summer until, February. Do you know it increased flu shot uptake by more than 30%? And they asked, it was the McDonald's idea, would you like fries with that? When they came for their flu shot, they were like, would you like your COVID vaccine? How about your pneumonia vaccine? Maybe your shingles vaccine could be covered either. And when you talk about bundling those point of care services, it doesn't cost any more, it costs less. And the uptake is great. It takes nothing to put, have you got your vaccine? Or would you like to get your vaccine? Or how about you've got an extra few minutes, we give you your vaccine. You're already at the pharmacy. Let me tell you, the pharmacists are delighted to do this because they spend so much of their time trying to work around the clock to provide really broad-based services for stuff that should be fast and easy.
And over here, Laura, if we use this mic, will I? No, okay, we're good.
I can run it like Oprah. Where are you? Got it. Oh, well, okay. I'm going to sit down and you can talk. I'm not going to tell you anything. Okay, go.
Dr. McFarland opened up a question that's been around for a long time. It keeps coming up every 6 or 8 months, every year. And the reason, the whole affordability of long-term care for elders in New Brunswick, when you look at long-term care, the actual hands-on services are provided by 3 different organizations. Nursing homes, which are funded under one model and regulated under one piece of legislation. And their funding model is antiquated, frankly, hasn't been reviewed in a long time, seriously. And then there's the special care sector. And that model was put in place, regulated under the family services legislation, which is light years different from nursing home legislation. And then those arrangements haven't been reviewed for light years. And then you have home care, which is the same thing. And so there has been some progress, thankfully, and some of my colleagues here have been pretty instrumental in getting those things on the table. But boys, there's a ways to go.
Yeah. Thank you. And thank you for all you've done for care, not just in this province, but actually across the Canada and around the world. Talk about having treasures among us. So really, truly, thank you. The structures that we have today are often because of the leadership of the gentleman in front of us here. It's rare that I say out loud the following statement: look to Alberta for their healthcare innovation. Bless their hearts. What they have done is they got rid of all the separate legislation around home care, around, they call them, there's 27 different titles in this country for that thing that you kind of pay into that's not quite part of the healthcare system, but you live at: retirement homes, seniors lodges, call it whatever you want. They scrapped it all and they wrote one piece of legislation called the Continuing Care Act, and it's pretty good. It's pretty good. And I know that legislators and drafters in this room and in other rooms close by are working very hard, and I'm every confidence that they're learning from their colleagues. But absolutely. And part of the other recommendations of the advocate is making sure that when you have qualifications for one program, that they're streamlined, right? You don't need to do it 4 more times. And if there is a change to your well-being or your financial supports, you shouldn't have to then do it. And the administrative burden on every one of those silos is ludicrous, right? So sometimes our technology is our friend. And what I would say is integrated legislation plus integrated qualification equals success in this, in my view.
I got 2 questions. John Grass, been in long-term care as a provider for about 29 years. First one from Dr. Samir, he suggested there, he stated that the ALC percentage across Canada is 15%. I thought it was around 25%, and in New Brunswick, we're 35%. So just get some clarity on that. And the next thing is, I really liked what Kelly said earlier about setting goals, and I like to be on the vision side of things, and I like to know, what does success look like, in 3 years' time? And in long-term care, in the special care home sector, we have about 400 members. Half of those are 10 beds and under. And so when I think about that, I look at the opportunity. Pretty much all of those homes would not have been a purpose-built home. So there'd be a residential model. And when I think about, if we could take, let's say they average, 8 beds, and if we could take those, if there was 100 operators that we could triple.
Yeah.
And so maybe, we could go from 1,000 beds to 3,000 beds, and we could free up of those 400 homes, maybe we could free up 100 homes, and those in the other, like what Danny talked about, he's looking for that community-based, non-purpose-built model. But in New Brunswick, we have silos. So it's a lot like the high school dance, where I got the girls on one side and the boys on the other side, and the boys are trying to figure out their problems and the girls are trying to figure out their problems. But they're really solved if we could connect these silos together. But I don't see today, and that's just me, but I don't see today how we're crossing the silos to put us in a position to win 3 years from now. So can you talk about that?
Well, it's not only New Brunswick that's got that problem, right? So the problem of the law of averages is it hides the specifics, right? We're talking about that. So if you're looking in numbers in waiting lists in Ontario, for instance, it's about 60,000 people on the waiting list for long-term care in Ontario. And the announceables are that they're building these giant homes, right? Which has had various degrees of success. And the thing about it is this: nobody wants the giant homes. Nobody wants to live in the giant homes. The giant homes cost now, well, 2024 numbers, $1 million a bed, right? $1 million a bed. And nobody wants to work in them. And if they could work in them, they can't find people to work in them anyway. So I guess I would answer for 3 things. First of all, I actually think New Brunswick is an extremely well-placed for innovative small home models. I really think it's extraordinarily well-placed. So start from success. First thing there is, we need to help home builders associations, universal design experts and advocates, local communities have conversations out loud that they're having at their dining room tables already. Every community in this province can tell you what place they think their, quote, seniors home or special care home should be. That inn, that bed and breakfast that's not being used, that church that's now not working in the same way with their community as they could be, that temple, that whatever it is, we all know where they are. Make streamlining renovation easy and understandable. You ask people what stops them from working into creating small homes in local communities. It's because, I don't know, the regulations. And it's true. You ever looked at, you look at the regulations, you made a lot of the regulations. Like, unless you are, I am a lawyer with a lot of experience on this, and I don't understand them in either official language, right? So you have to make an easy flow through for people who have interest in doing it, communities who have interest in doing it, and assign them coaches, local coaches, home builder coaches, healthcare coaches, and help the community to change and develop. If there's folks that already have trust in the community, and we know how important those are, right? And they're willing to expand, but it's a land acquisition issue. So often a land acquisition issue. You know what? Lots of people will say, you know, I'm not using that acreage. You can have it if you do this with it. And we can use the environmental model of giving trusts over into this. Lots of people really care about their community. They got 2 acres they're not dealing with. They'll happily give it to you, but no one's ever asked them. And so how can we talk to those dining room conversations creatively and say, how can we get the land? How can we make sure we get the people? So that's number 2. Start paying people by what they do, not where they do it. Start paying people by what they do, not where they do it. If you're in a acute care setting, you're getting paid, what is it, 35% more now? Is it 35? 35 to 40% more in terms of pensions, benefits, and dollars. And if it was a private agency for home care, you're getting paid more than you're getting paid if you're in the public. Like, start paying people by the work they do, not where they're doing it. And we can keep more people at home, and you'll have more people who are willing to go into home. And then my 3rd is culturally appropriate care. I sat next to a woman, I'll never forget this one. You know those moments that you just change everything? I was sitting, it was a Department of Finance committee meeting, which is not usually when I have giant epiphanies, right? But it was. And I was sitting next to this incredible woman who'd flown down from a very small village in Nunavut. And I asked her about what her community is thinking as it's aging, because it's aging, which is good because there's many reasons it wasn't aging. And she said, how am I supposed to tell my elders that they have to go to Ottawa or Edmonton to go into an institutional care wing, which tries as hard as it can. I mean, it has appropriate food, services, language, like it's tried hard. We have people who have to leave because of dementia and high care needs, and we're going to move them from their community into an institution where people don't speak their language. We are re-traumatizing people. Talking to a friend of mine who's Jewish, who is 95 years old, and her husband would not take a shower, would not go to take a shower in this wonderful, wonderful, wonderful home, like truly extraordinarily good long-term care home. I mean, just top notch. But it wasn't until they understood that that tattoo on his arm with numbers came from somewhere, and the showers came overhead spray. And so we just changed how showering happened into a different environment, and all of a sudden, he was able to bathe himself again. So the culturally appropriate care based on not just the local community, but the community of people is really important. And the solutions I really feel can be quite pragmatic. Coaches to help people get through and build on the success in small homes, integrate that legislation so they can stay in that community. And if we have a campus of care model, they can actually move from one level to the other without falling through it. Don't make them requalify with new financial appropriation every single time. Let the records follow with them. And then try to problem solve by who they are and what they need, not what we're tick boxing in decades old metrics. That's what I would say. But I also really want to say you've got incredible leadership in New Brunswick, and this is the province of we can. And I am constantly inspired, and I am openly volunteering. Anything that we can do to help and listen and learn and connect is truly a privilege. Merci, vraiment.
Thank you very much. That wraps up our day. Thank you, Laura. Thank you so much. Thank you to everyone who was here. I know it was a day full of lots of information, lots of good information, lots of frustrating statistics, but I think we're all leaving today with a full bucket. And I really appreciate that all of you came to join us. I do want to share that the new report, the recommendations monitoring report, is accessible on our website, the New Brunswick Advocate. So if you Google around, you will find that website, and it is under reports, so you'll be able to find it. In addition to that, Dr. Samir's webinar will be posted on our website too. So feel free to share that. And if anyone needs access to slides that were presented today or what have you, by all means, reach out and we will make sure that you get what you want. And then keep your eyes and ears open for, as the advocate said, one of our challenges is on older adults, and you'll be receiving it. If you've signed up for this, you'll be receiving, whether you like it or not, an invitation and our newsletters. So we look forward to seeing you a little bit later in the year. Thank you so much. Walewan, Walalan, and merci beaucoup.